Physiological changes in pregnancy is one of the most common topics students are not familiar with. In this video, I will discuss the physiological changes in pregnancy in relation to every body system, along with their physiological basis. This video is made using reliable and up-to-date information from recommended textbooks and websites for medical undergraduates and doctors. You can also download notes, questions, and flashcards related to this video directly from my Google Drive for free. The link is published in the description below. I highly recommend you watch the video till the end, and if you think this video is worth your time, please hit the like button, subscribe to the channel, and share this video with your friends. So, without further delay, let's get into the business, starting with the respiratory system. During pregnancy, the upper airway mucosa undergoes several histological changes. Its phagocytic activity becomes high to prevent the mother from getting respiratory infections. In addition, there is increased secretion of mucopolysaccharides, and glandular cells become hyperactive. These changes occur in response to the high levels of circulating estrogen, progesterone, placental growth factor, and interleukins. Because of these changes, the respiratory mucosa becomes edematous and friable, which increases the risk of epistaxis. Other manifestations due to these changes include nasal congestion and gestational rhinitis, which are resolved soon after the delivery, and sleep-disordered breathing. Additionally, Mallampati score increases during pregnancy, which increases the likelihood of difficult intubation. During pregnancy, the chest wall and diaphragm also undergo several changes. The abdominal component of chest wall increases, leading to increased chest wall volume. The compliance of chest wall decreases, especially towards late pregnancy due to increased uterine size. However, the lung compliance does not change. Due to the increasing size of the uterus, diaphragm moves around 1.5 to 4 centimeters cranially. Several changes occur in lung function tests as well. During pregnancy, the FEV1 to FVC ratio, peak expiratory flow, total lung capacity, static lung recoil pressure, lung compliances, and airflow rates remain normal. Functional residual capacity decreases owing to elevation of the diaphragm, reduced outward recoiling of the chest wall, and reduced downward tension of the abdomen. Expiratory reserve volume decreases by about 200 milliliters. The diffusion capacity of carbon monoxide, also known as transfer factor, increases during the first trimester, which gradually comes down as the pregnancy progresses and rises again postpartum. Respiratory rate does not change during pregnancy. However, minute ventilation increases. Increased progesterone level, high metabolic rate, and increased carbon dioxide production cause hyperventilation, which causes reduced PaCO2 and increased PaO2, resulting in mild respiratory alkalosis, which is renally compensated. Let's talk about the cardiovascular system next. Estrogen and progesterone hormones stimulate the renin-angiotensin-aldosterone system, leading to sodium and water retention and increased blood volume. Progesterone, prolactin, and placental chorionic somatotropins stimulate the secretion of erythropoietin hormone, leading to increased red blood cell production. However, as the plasma expansion is greater than the increase in red blood cell mass, women develop physiological anemia in pregnancy. The heart rate gradually increases over the course of pregnancy, which returns to normal at 14 to 17 weeks postpartum. Stroke volume increases, especially during the early months of pregnancy. Cardiac output increases due to increased heart rate and stroke volume. Stroke volume is the major determinant of cardiac output during early pregnancy, and heart rate becomes the major determinant as the woman reaches the latter stages. Blood pressure decreases due to reduced systemic vascular resistance. During pregnancy, uterine blood flow increases by 10% and renal blood flow increases by about 50%. Blood flow to the liver and brain does not change significantly. Oxygen uptake by the heart increases. In addition, ventricular wall mass, cardiac contractility, and cardiac compliance also increase. More than 90% of pregnant women develop a systolic murmur, which disappears following delivery. A small number develop a diastolic murmur. Normal ECG findings during pregnancy include the following: small Q waves, inverted T waves in lead 3, ST depressions and T inversions in the lateral and inferior leads, and left axis shift of the QRS complexes. Next up, we have the hematological system. Increased secretion of renin from the decidua and ovaries, and reduced secretion of atrial natriuretic peptides cause systemic vasodilation and increased vascular capacitance. Pregnancy is one of the most common situations where blood becomes hypercoagulable. It is an adaptive mechanism to prevent postpartum hemorrhage. However, hypercoagulability increases the risk of thromboembolism. Estrogen increases the synthesis of clotting factors 7, 8, 10, 12, von Willebrand factor, and fibrinogen. At the same time, there is a reduction in the synthesis of anti-clotting factors and fibrinolytic agents. Platelet number remains normal, but the concentration may be reduced due to hemodilution. Estrogen and other inflammatory mediators cause increased white blood cell counts. Renal system changes include the following. As mentioned above, renal blood flow increases, which causes an increased glomerular filtration rate. Due to this, serum creatinine, urea, and uric acid levels become low. Physiological hydronephrosis also develops. As glucose filtration exceeds the reabsorption capacity, women develop glycosuria. The effects of progesterone and relaxin result in relaxation of the ureteric smooth muscle cells, which leads to urinary stasis and increased risk of urinary tract infections. Gastrointestinal changes include the following. Relaxation of the lower esophageal sphincter and delayed gastric emptying can cause gastroesophageal reflux disease. Increased small intestinal transit time and smooth muscle relaxation can lead to constipation. High estrogen levels increase the synthesis of cholesterol, which results in gallstone formation. Endocrine changes are also significant during pregnancy. Human chorionic gonadotropin, or HCG, has several important functions. It stimulates the corpus luteum to produce progesterone, maintains the corpus luteum, and stimulates the ovaries to produce estrogen and progesterone until the placenta takes over. Placental TRH stimulates the secretion of TSH, causing increased thyroid hormones. However, free T3 and T4 remain unchanged due to the simultaneous increase in thyroid-binding globulins. These excess thyroid hormones are essential for the brain development and thyroid function in the growing fetus. During pregnancy, the pituitary gland enlarges up to 135% due to lactotroph hyperplasia, which causes increased prolactin secretion. Prolactin is essential for the development of breast tissue and milk production. Relaxin secreted by the placenta and decidua causes softening of the birth canal, relaxes pelvic ligaments, stimulates mammary gland growth and differentiation, and inhibits uterine contractions during pregnancy. Cortisol level during pregnancy is 2.5 times higher than normal. Cortisol is essential for fetal lung maturation and brain development. Estrogen, human placental lactogen, and cortisol hormones increase insulin resistance, which increases the availability of glucose to fuel the fetus. Increased endorphins and encephalins cause an increased pain threshold to counteract pain during labor. Finally, the dermatological changes during pregnancy include the following. Increased secretion of melanocyte-stimulating hormone from the placenta causes hyperpigmentation. Women develop melasma, linea nigra, and hyperpigmentation in the areolar, axillary, and genital areas. Estrogen prolongs the hair growth phase, thickening the hair. Increased cortisol leads to collagen breakdown, causing striae gravidarum,